So hello, everybody. My name is Pam Mendenhall, and I'll be the moderator for this session. And this session is there a difference in how we are treated at different radiology facilities? What about between medical centers and community offices? And so we are welcoming two doctors for this session today. Dr. Erik Mittra. He is a nuclear medicine physician at Oregon Health and Science University in Portland, Oregon. He is an associate professor of radiology, section chief of nuclear medicine, and program director of the nuclear medicine residency. He earned his MD and PhD degrees at Stony Brook University in New York, followed by further training at Stanford University in California. His research interests are primarily focused on the clinical translation of novel radioisotopes for imaging and therapy. So welcome. We'd also like to welcome Dr. Crispin Chinn. He is a medical director of nuclear medicine and the chairman of the Radiation Safety Committee at St. Vincent Medical Center at Providence Health and Services in Portland, Oregon. He specializes in diagnosing and treating injuries and diseases using medical imaging techniques such as X-rays, magnetic resonance imaging, and computed tomography exams. So thank you both for being here today. Welcome, and we look forward to your presentation.
Okay, so hi everyone. First off, I'd like to just thank Erik for including me on this. I'm honored to take part in the conference this year, though. So it should be kind of interesting because we both live in Portland, Oregon, and then Erik works at the big university, and I'm at more of a community hospital in Portland, Oregon. So I wanted to start off just to give some people some perspective just about myself and where I work at, and we can kind of contrast that to Erik's setting. And then I wanted to go through some different things, specifically, in radiology and what we do for thyroid imaging and cancer, and just compare it a little bit to what they might do at an academic center, and just show that what we can do at our hospital. And then I wanted to go some limitations just of my practices as I see them, being in a community hospital, as far as like resources and just basically what I'm able to do, and maybe when it might be reasonable to look for a higher level of care for thyroid disease, though, and then the things that basically I can and can't do. But the one thing I did want to stress is that I'm not going to go into it, but basically the key with any thyroid cancer and disease is really your endocrinologist and surgeon, though, and it's really widely variable. I know at our hospital there's like top-notch endocrinologists. I'm sure they are at academic centers too, though. So a lot of the care involved really centers, more on the endocrinologist and the surgeon too. So just a little bit about myself. I consider myself a private practice radiologist now. I did do a fellowship in nuclear medicine, and I finished that in 2003. I did do a brief stint over at Oregon Health and Sciences University, where I stayed on as faculty for a few years, but since about 2006, though, I've been in private practice at St. Vincent's doing, nuclear medicine and radiology too. So I did want to kind of define, the differences between our hospital and like a big university for purposes of this talk, though. And really a community hospital, there's really no good definition. Our place is really kind of more like a bigger, nonprofit medical center, though, where I work at, though. But some of the things that would be different from a big university, of course, there's no medical school, really no residents. The big thing is, we're a group of private practice radiologists, though, and we cover actually a few hospitals, and we have outpatient imaging centers that we do. And, it's limited research, all the heavy lifting and research, we leave that to Erik and the people in academics. So I wanted to throw in a few pictures, at least just give people an idea if you haven't been to Portland, though. But in the Portland, the city itself, Providence has two hospitals, though. The one on the left is the one that I work at, St. Vincent's Hospital. And then there's also Prov Portland. This is actually covered by a different private practice radiology group. But as far as like thyroid, we do some cross things where we work with each other, though. But it's pretty big between the two hospitals in Portland. It's over 1,000 beds, so it's a pretty big center. there though. And then I wanted to at least run some pictures. If you were going to come get treated at our department at St. Vincent's Hospital, just to give people an idea. Though I threw this one, it's kind of funny. We have this little small sign. Most people actually walk by it and don't notice this little door that to go into nuclear medicine. But the other thing you should see, it's like down this long hall. So it's obviously in the basement where most nuclear medicine departments are. I did want to show a picture of our technologist, Sasha, and she's the one that if you were going to get imaging or treatment, at least in the nuclear medicine department, she coordinates everything. And it's really nice at least having a dedicated tech to help with that. And then just one more image here too. I just think it's kind of funny with the times here. But this is our reception area, and I'd like to just say, like we were all set for COVID. We put in this big window with the big piece of glass separating the waiting area from the receptionist. But this is actually how they used to design things back in the 80s. So if you came into our department, though, you like notice that the reception area is a little bit dated. So for that, the next thing I wanted to talk about is just some of the things that we do in radiology, and I think a lot of the things, at least in our community hospital, and probably a lot of community hospitals across the country, they should really do these pretty well. Though I'll contrast a little bit with the academic centers. I did want to go into the treatment part of the things in nuclear medicine, not surgery or other things, but just as applies to our nuclear medicine department though. And when I get into the complicated things, that's where at least I think I have limitations in my practice though. But some of the stuff I'll go through kind of quick though too, but ultrasounds, this is something that we do a lot of at St. Vincent's. That between the hospitals and imaging centers, maybe 20 plus studies a day. And this is really the workhorse. Most non-academic, just about any radiology facility should be able to do a decent ultrasound though. One thing that has changed over the last few years is everyone should have started doing the Thyroid system though, and we started doing this in 2017 for characterizing thyroid nodules though. So if you happen to get a thyroid ultrasound, or maybe one of your loved ones gets a thyroid ultrasound, if they aren't doing the Thyroids though, they're probably a little bit behind the times at least though. But every nodule that you do on ultrasound, basically you give it a score. Here's just an example of someone that had a Thyroid 3 nodule, and it's based mostly on the appearance and calcifications, and then based on the size. And it's nice that they have published guidelines now that you didn't have like 10 years ago. You're basically back then we were biopsying anything over a centimeter, but now that there's guidelines on when to follow up and when to biopsy. So it's pretty clear now that hopefully everyone is following the same guidelines at all radiology centers. So after that, then what we do provide, and I think we do a really good job of too, where I work, is that if you have a nodule that actually needs to be biopsied, though, that's something that's easy to do. It's a very safe and easy procedure. One thing that's a little bit different that we just started doing recently now is our biopsies. The vast majority of them are being done by a non-physician. Now we have a physician's assistant that's doing a lot of our biopsies, and the nice thing about that is she does these every day, and she does a lot every day, versus if it was a radiologist, just when they're on that rotation, and here's just a sample schedule, on just a random day, she's doing like 4 or 5 thyroids. So she's quite good at it, and she probably does more of them than anyone in our practice now. So it's not like a negative to get an FNA by a non-physician. I did just want to throw this in too. If you happen to get a thyroid FNA, no matter where you're at, academics or university or non-university, you're probably going to end up with this Bethesda reporting system. I didn't want to go through it though, but the one thing I did want to touch on is, the one thing that might be usually dependent on the skill of the person doing the biopsy is the number of non-diagnostics though that happens, and this sometimes happens though they're just in the wrong place, or the needle technique is a little bit off, or it bleeds though. And to watch out, if you did have to get an FNA, is you don't want to go to a place where their non-diagnostic rate's super high, though, because then you have to go back for a second biopsy. In the If you took all comers, I think people report like 50% of the biopsies end up with the non-diagnostic FNA. We're close to around 10%, a little bit below 10% though. So, but I wouldn't hesitate getting an FNA. For sure where I'm at, and just probably any decent medical center or imaging center around to be able to do a fine needle aspiration of a thyroid nodule. Though here's just a picture of the needle going in if you've ever seen that. The next part of radiology is very important, at least for thyroid imaging, is to look for lymph nodes. This is something that is often done, especially when you get a thyroidectomy for thyroid cancer. And basically, at least where I'm at, this is probably the main imaging modality to look for recurrence, though, for people that have been treated for thyroid cancer. Though a lot of it is just ultrasound of the neck to look for recurrent lymph nodes, and then laboratory follow-up, though. So this is something that's easy to perform, and most imaging centers, especially at St. Vincent's, we're able to do. And if you have a suspicious lymph node, these are pretty easy to perhaps also. So at least for ultrasound, though, I think we're on par, and most community hospitals should be able to do a decent ultrasound. For that, I did want to talk a little bit about some of the other modalities in radiology. First off, CT. The one thing I did want to stress with and these are sometimes performed for thyroid cancer, usually when you think there's advanced disease, though. But there's basically two parts to getting a good imaging study. One is the images themselves, though. And then for neck CTs too, it's not like it's a real hard or complicated scan to do. So, any scanner at any imaging center, you don't need like the absolute best 256 slice scanner to get a good CT scan of the neck. It's not like you're imaging a moving heart, though. So any imaging, especially at St. Vincent's, should be able to do a decent scan of the neck. So that's the first part, is being able to acquire good images. The second part of any radiology study then is a report, though, too. You want to make sure you have a good radiology report. And I think for sure where I'm at, though, most of the head and neck studies, they're read by a CAQ neuroradiologist. So a lot of big practices have most of their exams read by a neuroradiologist, and someone has done a CAQ, they've done a fellowship and then got an extra certification for reading these. So I did briefly look just to see if anyone's did any published studies about the rates of errors in community reports versus like big centers. There's not like a whole lot out there that I could find. One thing did quote a 16% discrepancy in community reports that of patients got transferred to trauma centers. But I don't know, at least for the CT of the neck, it's kind of bread and butter and not that hard to read. Though, and then there's some other studies too, where even like in the same imaging center, if you like looked at reports from different radiologists, they found discrepancies, even a third of the time. So really, I don't know if there's much of a difference if you get a report read at a big academic center or your standard community hospital. Though it is nice, at least if you know that the person reading it has done a fellowship in CAQ, especially for neuroradiology. So basically for CT, I think you're safe getting that for sure at St. V's and other imaging centers or community hospitals similar to St. Vincent's. Same with MRI. Again, these are read by the neuropathologist, though. We don't do a lot of these for thyroid cancer. They're not that good for novel disease anyway. So a lot of times it's more of a problem solver, though. And just like I was talking about for CT of the neck, for the MRI scans for things like looking at for things in the neck for thyroid cancer or bone or brain metastases, here's just a couple examples. Someone had like a parotid nodule that they were working up, though, and here's a bone and brain metastasis. And this is something that, again, you don't need like the most up-to-date state-of-the-art MRI scanners to get really good images. You're not looking at real tiny blood vessels or anything like that. So just about anywhere that you go should be able to acquire a good MRI scan, especially if it comes to the point where they're looking for a brain metastasis or something in the spine. And again, all ours are read by the neural radiologist. So the next thing I wanted to touch on a little bit more is just because I'm more interested in nuclear medicine than what we're able to do at my imaging center where I work at. The big things in the nuclear medicine then are the whole body scan. You know, we have SPECT CT, it's kind of a newer thing, and then PET CT that we can offer. Right, and there's some academic centers are putting in things like PET MRI scans that we don't have though. But the standard bread and butter nuke med studies, though, you know, for sure, I think you can get an adequate scan. You know, at a non-academic center, though, the whole body I-123 scan, that's one where you swallow the pills and come back the next day. Usually we do these more for the intermediate and high risk patients, the ones that we're gonna consider giving treatment to, or someone where they're worried that, you know, maybe it's recurred. Though, all our scans are done, not all of them, but, you know, 95% plus now are done thyroid stimulated, though, where you get the shots beforehand. Though, versus being off your medications, that's something that we actually give in our department, though. And we can throw a SPECT CT. I'll show at least one picture on that. That's sort of a newer thing. And then a lot of these patients then would go on for the I-131 therapy. So I wanted to show at least one scan. And the kind of interesting about these nuke med scans, I actually like them, but you know, the amount of detail in these compared to a CT or MRI scan, you know, it's some black, you know, it's black and white. There's a couple of dots here, but these scans, you know, anyone should be able to acquire these, and you know, basically in nuclear medicine department, they've looked the same, you know, for at least the past few decades. When I started residency, you know, they haven't changed. But here's someone that has a spot in their neck, and you know, nothing in the lungs or nothing in the bones, normal bladder. That's good. Sometimes though, I will throw on a SPECT CT though, and this is something that we can do. We've had this machine for like the last 5 years, and basically it takes this same scan, the same tracer, acquires it a little bit differently, and then puts it on a CT scan there. And I do this every once in a while. There's some normal variants in the neck that it helps to sort out. And then, especially if you think someone might have like a bone metastasis too, it's nice to throw them on the SPECT CT scanner. So that's something that we can do. The other imaging modality that we do offer too is the PET CT. As far as for thyroid cancer though, it's not done a whole lot though. We don't do it routinely though. The people usually end up with a PET CT for thyroid cancer, you know, they tend to have like pretty advanced disease by the time they need one. It's usually people that have been treated with the radioactive iodine and their tumors have like poorly differentiated to the point where they aren't taking iodine anymore, but they will take up this radioactive sugar that we can give them. And we can do these. We do like maybe a few of these a year for thyroid, but we do like many a day for other types of cancer though. I know some places might do I-124 that we can't do at St. Vincent's, but that's pretty rare across the country. The other thing that we do offer though too is the gallium dotatate, which is a newer agent though that we can do for medullary thyroid. We've done a few cases for medullary thyroid. We actually use this a lot for things like carcinoid and other neuroendocrine tumors. So here's just like a PET CT, and I think even in town in Portland, like most of the big hospitals have their own PET CT scanner, and it should be able to acquire a pretty good study for a PET CT. There's some of that had, you know, pretty advanced disease though. So at least for the bread and butter nuclear medicine type things, again, I think you're fine, like getting most community hospitals getting these sorts of exams though. Next thing I wanted to talk about then was the therapy though, and I call this routine outpatient therapy versus more complicated therapy. All of the I-131 therapies that we are doing though, it's almost all outpatient now, and I call it routine. And I'll just compare that to the more complicated patients though. But these are the patients that are more intermediate or high risk patients though, and we probably do, I don't know, 3 or 4 a month of these though, where we'll give them anywhere from 30 millicuries to 150, sometimes 200 millicuries, depending on what we're trying to do. If we're just trying to ablate the thyroid remnant, or there's actually suspected disease somewhere, we can go higher though. Definitely on the outpatients though, depending on the circumstances, you can sometimes go up to 200 millicuries for these patients. In high risk patients though, I do tend to sometimes limit it, and other people will too. In older patients, you try not to go above 150 millicuries. But a lot of times these are pretty easy. The patient comes in, they're on their low iodine diet, and we'll go through all the different instructions and precautions that they should take as an outpatient. So for that, I think that's something that you're fine. Definitely coming to St. Vincent's for. The next thing though, this is where really I see, at least at our center, where we have some limitations for sure. I wanted to just share this one case. So here's somebody that had, basically this is a chest CT scan that it's basically normal. There's nothing there, but they ended up getting a iodine whole body scan, and sorry, it's kind of divided up in three sections. So, and if you remember that other one I showed, there's basically nothing in the lungs. This person has diffuse uptake throughout both lungs, and also uptake in the mediastinum though. So if this person eventually went on, I don't remember the timing of when the CT was obtained, but eventually they started showing these real small lung nodules from metastatic disease. So this is what I refer to as at least a complicated case that I would have a hard time adequately treating at St. Vincent's. And a lot of it has to do with, for someone like this, you're going to want to maybe give a bigger dose than the 200 millicuries that I could potentially give as an outpatient. And the problem with giving bigger doses, especially some of lung meds, is you start to worry about over radiating other critical organs, especially the lungs and bone marrow. And I was hoping Erik would talk a little bit about how he would handle those patients with something called dosimetry though. So when we get these complicated patients, especially when you have to give higher doses or dosimetry, that's hard for me to deal with in my practice at least. And other thing that's nice too that we don't really have, and a lot of the community hospitals probably don't have, is a multidisciplinary tumor board just for thyroid cancer. We do have something for ENT, but really nothing for thyroid cancer. There's sometimes where I do always talk to the endocrinologist. It's nice to have maybe a room of like a few endocrinologists and a surgeon and a nuclear medicine person to really go over some hard cases in a tumor board setting. So that's in this situation, I really think it might be reasonable to seek a higher level of care than what your normal community hospital can offer. And the other area where it's not hard, but for just about everything I do is outpatient though. When you have to start doing inpatient therapies, though, things become more complicated. A lot of it's just logistics. So it's not real hard to do, but as far as like the nursing staff, we don't have a room that's lined with lead though. We can send them over to Prov Portland to do that though. And just the technologists, that over time they don't do enough of them. They forget how to set up the room, and then just monitoring it and cleaning up the room. So that's another area where I have a hard time, and I think probably some other community hospitals might have a hard time with inpatient therapy. And the other thing, you might have a patient that doesn't have like really bad disease, maybe it's intermediate or intermediate to high grade, but other concomitant medical problems, especially like renal insufficiency or low blood count cytopenia. Though you have to be a little bit careful, especially with those patients. Just anecdotally, I've had patients with a low white blood cell count just at baseline, and we treated them, and then like a few weeks later they're in the hospital with like urosepsis. That patient actually did fine though, but especially with other concomitant medical problems, so you have to be a little bit more careful and I think sophisticated with your I-131 treatment. So in summary, at least from my perspective, I think most of these things you're fine as far as getting your workup and diagnosis and surveillance. And most community hospitals, for sure at St. Vincent's, with ultrasound, CT, MR, the spread and better nuclear medicine exams, and just routine I-131 treatment. But at least a limitation for me is when things start to get really hard with the more complicated patients, is where I've actually in the past even like told the endocrinologist, you're gonna have to send that patient to HSU to see what they can do for them. So that's all I had, basically with my slides. So I didn't know if Erik wanted to go ahead and take over.
Yep, sounds good. Thanks, Crispin, very much for that presentation. So I'll go ahead and share my screen. Okay, so Crispin did a great job kind of explaining the framework that is available at a standard community hospital. So what I'm going to try to do is to build on that and really try to highlight what is different in an academic medical center compared to that. So I won't address a lot of the background things that he did, because as he alluded to several times, a lot of that more straightforward stuff it's all the same at OHSU as well. And so what I'm really going to highlight is what's the difference. So I'll start with what really is an academic medical center in terms of definition, and then like he did, I'll talk a little bit about myself and our team in nuclear medicine and molecular imaging at OHSU. I'll go over some of the infrastructure that we have and how we link with other departments and divisions, and then really focus in on what the academic medical center can provide in the context of thyroid cancer and what the differences might be from my view, and then leave time for questions. So what's the definition of an academic medical center? As Crispin alluded to, basically the main thing is that we're affiliated with a medical school. So that's a large part of what we do, is provide graduate medical education, not just to medical students, but all sorts of other trainees as well. And also, as he mentioned, research is a major part of an academic medical center. And lastly is that we offer high-level care. So examples are, we have level 1 trauma and burn centers, and we are used to dealing with complex patients. So in terms of the overall number of hospitals in the US, academic medical centers are a small number, less than 10%, but we deliver a large amount of the care to certain specific groups, such as those who are underserved, high acuity, and then again, research patients. So my background, I did a combined MD and PhD in biomedical engineering, and then I went on to do a residency and fellowship at Stanford. And one of the differences that you'll find in academic medical centers versus community is that I only trained in nuclear medicine. I don't do any other radiology. And I spent several years doing that, plus a fellowship. People like that are really only found in academic medical centers because we're so hyper specialized, and we don't really have a role in more community settings. I stayed on at Stanford for 8 years before I was moved to OHSU to take over as the section chief for nuclear medicine here. And aside from clinical care, which I do approximately half the time, the rest of my time is involved in these other things. So again, I'm very interested in clinical trials and doing research. I do very much enjoy teaching medical students, residents, and fellows. I'm very involved in regional, national, international societies, not just for radioiodine therapies, but for other things as well. And then I do give a lot of talks throughout the year and participate in advisory boards. So that's kind of the role of an academic physician, is kind of varied across all these different things as well, which I personally really enjoy. This is our team at Nuclear Medicine and Molecular Imaging at OHSU. We have 3 faculty listed on the very left here. Again, I'm the section chief, but then Dr. Malak and Dr. Kozlov also have multiple years of training in nuclear medicine, but they also do radiology as well. We have a radiochemistry center called the Center for Radiochemistry Research, and these are the radiochemists that are involved there. This is our manager of nuclear medicine, Adam Brown, who oversees approximately 10 nuclear medicine technologists within the division. And then we have several physicists. The lead person is Dr. Griglock, who helps oversee all our imaging equipment, but also helps with our dosimetry, which I'll talk about. And then, of course, we have a lot of affiliations. OHSU is quite a large academic medical center, and so there's many different areas that we kind of overlap with that are listed here. I wanted to talk a little bit about what's going on at OHSU. The whole field of molecular imaging is really changing a lot these days, primarily related to these types of therapies that we're talking about. So in the past, within the large medical center, there was one PET-CT scanner, and then this is our main clinic, which doesn't look too different actually from the clinic that Crispin showed. And there we have 3 SPECT-CT scanners and then 1 SPECT alone. And then I just mentioned this Center for Radiochemistry Research, which is primarily, as the name suggests, for research purposes, but we can do some clinical trials through there as well. And then in the future, there's a lot of changes that are going on. So back in 2018, we replaced the scanner that we have, PET-CT scanner in Beaverton Clinic with a new digital PET-CT. And then earlier this year, we changed the one at OHSU, the main medical center as well, with another digital PET-CT. And then we're in the process of building out a nuclear medicine section in the South Waterfront, which is where the Cancer Institute is located. So we'll have some imaging capabilities down there as well. And then next year, Crispin mentioned that some academic medical centers are getting a PET MR scanner. So we're actually getting one of those next year. And then probably the most exciting is that our entire clinic is actually moving to a new area out of the basement for once. And so that's going to be really nice. And we're going to develop a from the ground up this radiotheranostics center. So it's going to be very nice with all these windows. It's on the top floor of one of the buildings, and we're going to have a therapy center. And we're going to also, one of the main things we're going to build there is a consultation room for all our therapies. Nuclear medicine is kind of evolving more towards a clinical oncology specialty, essentially. And so we're going to try to enhance that aspect to it too, to be able to explain everything that we're doing to our patients in detail before we do it. So I just want to give you a little bit of glimpse. Crispin again talked about a lot of the kind of standard stuff, but just to put it in context, in terms of our imaging and therapy, we do every type of FDA-approved imaging that's available, and I'm focusing here only on PET tracers for cancer. So you can see that over the years, there have been a number of different tracers that have been approved, including one earlier this year for breast cancer. And so we do all of these types of imaging, with the exception of this first one, only because it's not reimbursed typically anymore, but we are going to do all of these other ones. And then we, even outside of oncology, we do a huge amount of different types of imaging, again, just focusing on PET for brain imaging and cardiac imaging as well. So we try to be very comprehensive in everything that we do. And that's also true, before talking about therapies, also in terms of the future, same thing, we really always are trying to be at the leading edge of what we can offer and what we're practicing. And so a couple of new tracers that have gained a lot of interest for prostate cancer and some other cancers, we are participating in the clinical trials for these agents, and then hopefully they'll get approved. And then if you look out even further, there's a tremendous amount of research, and this is where the research side of the academic medical center comes in, is because we get to participate in the development and trial process to bring these to market, and that's can be advantageous for patients as well, to be able to have access to some of these novel agents. So I was saying, even on the therapy side, same idea. The one that we're talking about in this talk is radioiodine therapy for thyroid cancer, but we do a huge number of different types of therapies. Most of them are related to different types of cancer, but also for some other indications as well. So, and then similar to on the imaging side, that if you look into the future, again, we're participating in multiple clinical trials for novel agents for therapies for cancer. And then if you look into the farther future, there's so many different things that are on the horizon. And this is, one of the reasons why we're trying to develop this radiotheranostics center from the ground up, because we know that there's a huge amount of things coming down the pipeline. And, I get a lot of satisfaction in terms of participating in these trials. But again, the main reason we're doing it is to be able to offer it to current patients, and then especially for future patients once it's FDA approved. Okay, so what does the academic medical center specifically offer for thyroid cancer? And again, here what I'm trying to focus on is things that go beyond what Crispin already talked about in terms of kind of standard imaging and therapy for thyroid cancer. So one of the things I'll highlight is that we do have a very comprehensive group of physicians, not just within nuclear medicine and radiology, but also with many of the other departments and divisions, which are very integral to thyroid cancer care. So the people listed are the main people in these sections who are involved in thyroid cancer. Dr. Madison leads the thyroid cancer clinic at OHSU, and Dr. Senashova, who Crispin actually used to work with previously, has now moved to OHSU and is our other main thyroid cancer person. And then, of course, in ENT and endocrine surgery, we have several different physicians there as well. And I'll also highlight that one of the things that you often really only see in academic medical centers is dedicated people who are focused on this type of thing just for a specific type of cancer within pathology and even within laboratory services. So believe it or not, there are some differences to how labs function in terms of even standard tests. When it comes to thyroid cancer, thyroglobulin and anti-thyroglobulin antibodies, there's a lot of different assays that are available. As a general rule, as a thyroid cancer patient, it's important to try to go to the same laboratory so you have consistency. But I feel very confident in all of these different groups in terms of providing very good support for what we do in nuclear medicine. Crispin mentioned about the Multidisciplinary Tumor Board. So in general, what a MTB does is have multiple different types of physicians and allied healthcare professionals who all come together in the same room and discuss patients. This is, again, primarily useful for those people who have more complicated disease, and it's perhaps questionable exactly what is the best approach. And so it's very, very useful to have everyone together in the same room discussing everything. So usually somebody will present and then everyone else will chime in on these things. And we do have a thyroid cancer specific multidisciplinary tumor board at OHSU that meets regularly to discuss those patients. So that's something that is found in every academic medical center. The other big difference is the ability to do inpatient therapies. So in one of the oncology units, there are 3 lead-lined rooms that we can use for our radioiodine therapies, as well as some other types of inpatient radioisotope therapies that we do. This is just an example of a room that was prepped by our technologists to have this. So everything is lined, the bed, the floor, the bathroom, so that if there's any contamination within the room, that's all contained. And again, all the walls are lead lined. You're not able to otherwise see a difference in this room compared to the other rooms. It's a very nice oncology wing, but this is where we do that. I would say for radioiodine therapies for thyroid cancer, it's relatively rare the need to do this. It's typically for for social reasons, when a person can't isolate themselves from other people, or they potentially have issues using a separate bathroom and so forth. Those are actually the main reasons we end up doing an inpatient treatment. And we do it not commonly, maybe once every 2 months or so. But nonetheless, we do have the capacity to do it. And certainly if there was a medical necessity for it, which is even more rare, then we could do it for that reason as well. These are just some examples of what this pre-therapy dosimetry is that we talked about a few times. So the idea is that every person, if you give them the same amount of isotope, will clear it from their system in different rates. And so it's very important to kind of know what is that specifically for that person. And this is most useful for a patient like this who has very extensive disease. And what you don't want to do with the therapy is be able to treat the disease, but then cause other harm in terms of bone marrow toxicity or toxicity to the lungs and cause radiation damage. And so that's why we do this dosimetry. As he said, when we're going over 200 millicuries, it's important to make sure that you do pre-therapy dosimetry. And it is quite involved. It takes multiple days, as you can see here, to get the scans done. And then you ideally need a medical physicist to help with the calculations, which can be kind of involved. And so those are primarily the reasons why this is not done in non-academic medical centers. There's actually a lot of different techniques for doing this that range from simple to complex. But what we're really trying to do is evaluate for a specific patient what's the highest activity that we can potentially give that's not going to cause any harm. And we can do calculations for the whole body, or for patients who have specific disease in the lungs, we do other calculations. So we do these also pretty rarely. I would say maybe only a few patients per year really need this done, but we do have the capacity to do it. Okay, so ultimately, what's the difference between community versus academic medical center when it comes to thyroid cancer, in my opinion? As both Crispin and I have said, the standard imaging therapy are relatively similar. The potential advantage for the academic medical center is for complex patients. We do have the multidisciplinary tumor board. We can do inpatient therapies. We can do pre-therapy dosimetry. And it may or may not be applicable to some patients with thyroid cancer, but we do have access to multiple clinical trials as well, which can be useful. What about some potential disadvantages for the academic medical center? Well, as I mentioned, this is a teaching hospital. So when you come, you will, come across residents and fellows and trainees, and that's just part of, what happens there because they need to get trained. But, some people actually see that as a disadvantage because they don't want to, deal with someone who is just learning, and it can potentially take a little bit more time because of that, because you have to talk to them, and then they'll come and talk to the attending, and then, we'll convey. But I will say there's a pro to that as well, is in that there's multiple doctors who are kind of involved in your care, even for something straightforward. So there's kind of just a double or triple check there. And I actually gain a lot from working with the trainees, because oftentimes they'll ask interesting questions or pick up things that I may not have. And so it leads to a more thorough discussion. So there's sort of pros and cons there. Academic medical centers generally are much larger, and it sometimes can be more difficult to navigate. I know that at OHSU in particular, when you come to the main medical center, it's a little bit hard just to find parking and then to know where you're going. So that can sometimes be a little bit challenging compared to a community center, which is usually smaller and easier to navigate. And then our imaging equipment can, again, kind of be, that one I would say is variable. So as I mentioned at OHSU, we've really updated everything that we have, but this is just a prompt to remind me to tell you that, that it doesn't always mean that's the case. It just depends on which center you're going to. A lot of community hospitals have actually updated their equipment more recently, perhaps in a different academic medical center. So that's just something you need to kind of know about that specific department or division. And certainly you can ask people if you're interested about that. So this is a lot of the people that I mentioned. Just wanted to acknowledge that it's a huge team effort what we try to do at OHSU, and thanks to a lot of different people that were able to do it. So with that, I'll stop, and I think we have a little time for questions.
There is one question in the queue, but I also have a question, and as a co-host, they're not letting me type mine in. So I'm just going to ask. I received my radioactive iodine treatment at a local community hospital. And I also had my thyroidectomy at a local community hospital by a general surgeon who was very well, well known and versed in thyroidectomies, however, not thyroid cancer. So when does a patient when does a patient need to ask the physicians if they are able to and equipped to handle this? Because in a subsequent surgery, I found out that I'm BRAF positive, and they left a lot of disease in. So I had radioactive iodine, and it may not have actually worked because my TG went down, but then it started going up again. So I guess the thought is, when do you know what you don't know what you don't know.
Crispin, do you want to take that first? Or?
Yeah, that's kind of interesting. It's a little bit hard for a while. Every once in a while, it hasn't happened recently. We get like a case of like when a general surgeon would do the thyroidectomy. I think in the past, though, it was pretty commonly done though, but they would tend to leave more tissue though than like a dedicated ENT surgeon, though, which I think may have happened in your case though. But we really haven't had any general surgeons doing thyroidectomies though for like the past few years. And I think a lot of it, if I was a patient and didn't really know any better though, I'd probably, I don't know if you saw an endocrinologist before you saw the surgeon though, but the endocrinologists usually know who would probably do the best job. I don't want to throw any surgeons under the bus either of them. But
I would say that my case history is an exercise in what not to do ever with a thyroid patient. So
I would, if I could add to that, I would say that I think I would always try to advocate for all patients to really ask those types of questions up front, no matter what it is, really. I mean, like across the board for their medical care, but especially when it comes to cancer, things that are potentially more complicated. I think it's always a very fair question to your doctor to say, what experience do you specifically have with this thing, and how many patients do you treat, and what complications do you have, and things like that. But I do know, in talking to lots of patients as well as friends and family, that unfortunately a lot of people don't ask those questions. They sort of just assume that whoever you get referred to is going to take care of it. And I don't know how to, but all I can say is just spread that word that you should always ask.
Yeah. Okay, did you want to take a quick look at what is in the Q&A down there?
Yeah.
Okay.
So the question is, would the treatment plan for a 21-year-old adult with central nodal metastasis be different at a community hospital versus a large teaching institution? I can take that first. Just to say, I would say that's tough to say. Without knowing a lot more of the details of exactly what the extent of that disease is locally. It sounds like it's a little bit more extensive there. I think one of the potential differences between those is what we had both talked about, which is that a patient like this would probably get presented at our tumor board, and everyone would kind of weigh in. So at least at an academic medical center, you have the confidence that everyone is in agreement with doing that. As far as whether the actual specifics of the care end up being different, that's hard to say. It just depends on who is doing that at the community hospital.
Yeah,
what do you think?
Yeah, no, I agree. I'll tell you, if that patient would come to St. Vincent, so we would probably do the whole body scan, though. I'd take a look at that. Then we won't have a tumor board though, but it would warrant a call. And yeah, I'd go back and forth with the endocrinologist. We'd review the case, look at the path report, kind of assess the risk, and then come up with the dose that way. Though I imagine, sometimes too, like it depends on the endocrinologist too. Like some people like to treat higher than others too, though. It's not the problem with it. People specify a range, at least in my experience, on what you can do, and I'll usually do it with what I think is reasonable for sure, though. But I bet we would come up with pretty much the same dose.
Yeah.
So at OHSU and St. Vincent. So, but that's how I would approach it.
Actually, the talk that I gave just before this was about how much there are so many so many things that are known about thyroid cancer treatment, but also so many controversies about it. There's every aspect of it is debated one way or the other. So that's the other thing to keep in mind, is that even if you went to 2 or 3 different academic medical centers or 2 or 3 different community practices, you're going to get some variability there. It's all going to be in the kind of general range of the same thing, but there's always going to be some variability there. So it's hard to be. Do you always do a pre-therapy whole body scan before doing the treatment, or not always?
Oh yeah, no, always pre-therapy. Yeah, and a lot of that too is, at least back a few years ago when we get like some from some general surgeons, if you'd be surprised on how much would be left over, and then you do the pre-therapy scan, and just it really would change your treatment plan a lot, especially on that type of patient though.
Yeah, totally. No, that is, I think, something to stress again, that having a surgeon who really does this a lot and has good outcomes is one of the, I would say, one of the most important things, because the radioiodine subsequently, like you said, is more or less the same at most places that you go. So,
I have another question, if it's okay. So why does the instruction vary so differently from doctor to doctor about how long you should be staying away from people and what the rules are? And, the instructions just seem to be very varied.
Yeah, so that's again an example of what I'm talking about in terms of some of the controversies around it. For that specifically, my take on it is that no one really knows what the risks truly are of this type of relatively low dose radiation in terms of harming a family that you're around or other people. And because it's not very well known, there's no way to really document it. And so some people tend to take that to mean that they should be very, very conservative, and other people take it to mean not so conservative, and that's what leads to all these variability. I know it's definitely very frustrating for patients. At OHSU, when I moved here, I noticed that there was even different opinions being told within the same institution. So endocrinology would say one thing, the surgeons would say something else, and then they came to nuclear medicine and we had a different opinion. So we actually spent a considerable amount of effort to make at least OHSU uniform. Now we have the same exact sheet that's given to the patient by the endocrinologist, and that way they have a chance to read that over, and then by the time they come to nuclear medicine, and we say the exact same stuff. But yeah, I bet between Crispin and I, there's probably a good amount of variation there.
Oh yeah, no, I'll tell you what we did when the American Thyroid Association came out with their guidelines on radiation safety and what to had like kind of specific things on the number of days just to stay away and everything. I went through that very carefully with my colleague on the other side of the river, and we came up with this instruction sheet. And it's pretty detailed, and it's like 2 pages though, and we used that for maybe a year or two. But as it turned out, then subsequently he actually went through like with another endocrinologist there, and it was just even going through the guidelines, it was still confusing on what to do. So we basically went through and like simplified it even more. Though it's like kind of based on the guidelines and kind of based on what's easy for a patient to understand and do too. So I think if they were going to come up with guidelines again, though, they should maybe simplify it a little bit to make it easier.
Mm-hmm.
And it looks like we have another question here. My endocrinologist had me start the low iodine diet prior to scheduling RAI. Does that sound right at all? And how quickly do your own facilities usually schedule out RAI?
So I could start. So yeah, the general rule for low iodine diet prior to RAI is 1 to 2 weeks on that before doing it. And a few rare places I've heard do it for longer than 2 weeks. So then it just kind of depends on how quickly the RAI can be scheduled at our institution. We can do it pretty much anytime. We're certainly not at some limit to capacity. So it typically just depends on when the thyrogen can be ordered, And then around that is when, so you just we do 1 week of low iodine diet. So then once that's scheduled, then you start the low iodine diet 1 week prior to that. And then, like I say, for the actual radioiodine, it's easy for us to do that at any week.
Yeah, we do the same thing. So sometimes when we are kind of hampered by the schedule, those when we can get the I-123. I think there's actually only certain days that we can get that. We can get the 131 just about any day to treat though. But for doing the scan and then timing with the thyroid shots, so usually we like to give the shots like Monday, Tuesday, and then scan and then plan to treat like a Thursday, Friday though. But with the low iodine diet, it's like one or 2 weeks. So and yeah, ideally we could probably get someone in like within like a week or two if they wanted to really push the schedule.
Yeah, that's actually one big difference for us is that we don't do a pre-therapy whole body scan. So it's interesting because where I trained, I definitely learned to do that, but here the practice was not to do it. And after really delving into it, I see that in fact, both ways are quite reasonable. So we actually don't have to worry about that part.
Oh, it makes it easier.
Yeah. Another question is the RAI given liquid or capsule? And for sure, we try to give capsule whenever we can. Only in rare circumstances, if the patient isn't able to swallow a capsule, do we do liquid. And the reason is because this is high dose radiation, and having it in liquid form is potentially very dangerous. It can spill somewhere. It also can turn into a gas and go into the atmosphere. So we have to do the rare patient that needs that, we have to do it under a hood, and it's very controlled. So whereas a capsule is very easy, it's contained and you just swallow it and it's done.
Yeah, and we're almost always capsules, and I think we have done liquid before, but I can't remember. I think we had a patient like last year that wanted to do liquid, so we looked into it again. I think it was almost impossible to get. I think they used to give you a container with a straw for patients to get. I don't even know if that's offered anymore though. It'd be really hard if you had like a kid, like a pediatric patient. I'm not sure. We'd probably send them to Erik to figure out what to do.
We have
swallowing pills.
Yeah, from the community, we actually had over the past couple of years 2 referrals to us specifically for that. They said that patient was able to swallow pills, and so they weren't able to get the liquid iodine, so they came to us for the liquid iodine, and we can get it, but I actually consulted with the patients initially, and both of them I was able to get them to swallow pills. So one of them I had to actually send them to speech pathology, and they worked with them over several weeks to learn how to. This person had never swallowed pills before in their life, and the other one just always said it would kind of get stuck, but we were able to get through, so neither of them had to ultimately get liquid. I do everything I can to avoid it.
My daughter, when she was 10 years old, this is Pam, actually had the liquid RAI. I don't know if it was because of her young age, but they brought it in a concrete block with a straw in it. So she drank, and then she ended up coughing as she was drinking it, and everybody jumped away real quick. So I think it was probably dangerous.
Yeah, liquid iodine is not safe to use. So like I say, unless you absolutely have no other option, then we do it. But
okay,
I can read this.
One more question here. We got about 1 minute.
Okay, so this question says, I had papillary thyroid, no RAI, no whole body scan, just thyroglobulin levels and ultrasound, multifocal disease, non-BRAF. So one side was larger, the other side was microscopic. Should I have other tests or radioiodine? It was contained inside the gland. My take on this would be that given that the tumor was, not small on one side, and then the other side was BRAF positive, I think it would be not unreasonable, certainly, to consider radioiodine in the circumstance. I don't know rest of the details in terms of local, it says contained inside the gland. Yeah, I don't know. I think it could go either way, but I would probably have a low threshold for RAI. What do you think, Crispin?
Yeah, no, I agree. I assume they did a lymph node dissection and all the lymph nodes were negative then too.
Mm-hmm.
But yeah, in that case, you might want to at least consider remnant ablation for something like that. So
Yeah, yeah. Not a clear answer, but I think that would be reasonable.
Okay. All right. I think on that we will wrap things up. So I want to thank you both very much for your time. It was very informative and hope to have you back next year. So thank you very much.
Thank you for having us.
yeah, thank you. It's fun.
Bye-bye.
Thanks, Erik. Yeah.
Bye-bye.
Thank you. Thanks, Crispin. Bye.
Yeah.